All right, we're going to go ahead and get started. People coming in, we filled most of the seats, never mind. Good morning. This is a session that is presented by the Physician Assistant Education Association. There will be several such sessions in this room over the next couple days. And for those of you who are preceptors who want to be, you may want to come to the one tomorrow on getting credit for that. CME credit, and there's some other good things for anybody who has interest in faculty. But our session this morning is Obesity Management in Primary Care. Our speakers today are Patricia Marincic and Carrie Gray, and this is being recorded, so if you have questions at the end, please come up to the microphones. Thank you, and please welcome our speakers.
Okay. Good morning, everyone. My name is Carrie Gray, and I am a physician assistant who's practiced in family medicine for about 12 years now. I'm actually currently in my 4th year at Augsburg's PA program in Minneapolis, Minnesota. My colleague and co-presenter today is Dr. Patty Marincic. She's a registered dietitian, holds a PhD in nutrition, and in addition to her job at Augsburg, she also works for a large healthcare institution in Minneapolis, providing nutritional therapy for patients. So we're excited to be here to talk to you guys today about obesity management in primary care.
Can you speak up or get the mics?
Yes, I'm sorry. Is this better? Yep. Oh, yes, a lot better. I'm so sorry. I wasn't realizing it wasn't picking up. Anyway, we're excited to be here to talk about obesity management in primary care. Specifically, we're hoping today to talk about the CMS, the Center for Medicare and Medicaid Services guidelines that are recently out in the last year and a half. Make sure everyone is aware of those, as well as to try to help you gain some target strategies to implement their recommendations of behavioral therapy for treatment of our patients in primary care, in addition to some of the other treatment options that we already know about. So we have a lot we want to cover. So I'm just going to spend a few minutes talking about the CMS coverage, the specifics of that, as well as some barriers that we all face in trying to help our patients with weight loss. And then Patty will be spending the bulk of the time giving us all direct targeted strategies and tools that we can use to hopefully help our patients lose weight and keep it off. So I think we all know that obesity is a national epidemic. However, I still find the numbers shocking when I look at them. Obesity, which basically is patients with a BMI of 30 or greater, and then the diagnosis of overweight, which is a BMI of greater than 25. Those two conditions combined are the second leading preventable cause of death in the United States. And the key word there is preventable. It's second only to tobacco abuse, which you probably already know. More than 1/3 of U.S. adults are obese, and every 2 out of 3 adults are overweight. Just as concerning to me is the fact that childhood obesity has tripled in the past 30 years. At this point, approximately 17% of children ages 2 to 17 are obese, and about 1 out of 3 are overweight. We know that obesity, there is an association with increased mortality, as well as links to diabetes, hypertension, hyperlipidemia, sleep apnea, arthritis, and other conditions like GERD. So knowing that, unfortunately, insurance coverage has been sporadic at best, and it varies from state to state. And more specifically, even CMS coverage has varied. And I'm going to come back to this in a second, but I just want to jump forward for 1 second and just remind everybody about the fact that obesity treatment is on a continuum. Hopefully, we're all doing our best to try to help our overweight and obese patients with lifestyle modifications in hopes that that will help them lose weight. Now, some of those patients may also be open and candidates for medication therapy. That'll depend partly on BMI, other risk factors, their ability to tolerate medications and what those risks might be. And then obviously if patients aren't able to lose weight with those therapies and they're open to it and meet the qualifications for surgery, they may be candidates for that as well. But I do think if you asked a lot of patients, and some of us providers as well, what's the most difficult of these things to tackle? most people would probably say the lifestyle modification stuff, and that's really what we want to target today. We're not going to be spending time talking about medication and bariatric surgery. I think there is actually another talk that's going to be talking about some of the newer medications maybe later on. So we're going to be focusing on the lifestyle changes and what we can do for that. So if we go back for just a second, I just want to point out the results of a study that was done by Lee and colleagues. In 2008, they took all of the state Medicaid manuals and reviewed them for obesity treatment coverage. Now, they did find that all states did cover at least one form of obesity treatment. However, the most commonly covered was bariatric surgery. About half of the states did cover some form of nutritional counseling. However, several of those did have limitations to it, and only 8 states actually covered all 3 treatment options. So there's definitely room for improvement there. So interestingly, CMS has actually only recognized obesity as a disease for about a decade now. In 2006, we did start to see reimbursement for bariatric surgery. And finally, in November of 2011, CMS did implement national coverage for obesity management in primary care, specifically targeting behavioral therapy, and that's what we're going to talk about today. So what is CMS recommending that we do in primary care? Well, they want us to screen our patients for obesity using BMI as the measurement. Then if patients are obese, then they want us to do a dietary or nutritional assessment. And that, will include things like, what are their dietary or lifestyle habits, what are barriers to treatment, those sorts of things. And then they want us to take that information and use targeted behavioral counseling to try to help them lose weight and hopefully maintain that. And these recommendations are based on the 2003 U.S. Preventative Services Task Force recommendations. And that organization actually updated their recommendations and were published in June of 2012. And they continue to support what CMS has put into place. So why primary care? If you're like me, you are perhaps a little uncomfortable about thinking about the daunting task of using behavioral counseling techniques to help our patients. But it sort of makes sense. We typically have very close relationships with our patients. We often see them multiple times a year, which means multiple opportunities to target weight loss. We're usually pretty familiar with their medical and social circumstances, i.e. barriers to care, and hopefully can help them to address that. Also, provider advice is a strong predictor of weight management efforts in patients. Studies have actually found a 3-fold increase in patient attempts to lose weight when their physician recommends that they do so. And I'm not talking about actually giving them the tools. I'm just saying just recommending weight loss, a 3-fold increase. So just by recommending it, we actually do have an impact, even though it may not feel like it. And there's actually fair evidence that supports efficacy of moderate weight loss in the primary care setting. Now, CMS defines moderate weight loss as 3 to 5 kilograms, or about 10 pounds, that is sustained over a year or more. And a lot of us may think, gosh, 10 pounds, really? When we consider the weight of some of our patients. But we're going to talk about that in a minute. So I think some of it is adjusting our goals somewhat and maybe having some satisfaction in some weight loss. Some is better than none. So intensive behavioral therapy, there are a lot of different models out there. However, CMS and the U.S. Preventative Services Task Force does recommend using the 5A framework model, which the 5 A's are assess, advise, agree, assist, and arrange. So assess is obviously making that diagnosis, but it's also then taking that nutritional assessment as well as exercise and other lifestyle things into consideration and finding out what the barriers are and patients' willingness to try to change some of their habits. If patients aren't willing, then it may not be the best time to do it. Advise is that part where we take that information and actually give them directed strategies, and that's what Patty's going to be spending the bulk of the presentation talking about, trying to give you the tools for that. I think one of the most important A's here, however, is agree. I would strongly encourage you to get your patients involved in making the decisions on what they want to specifically target. because if they're part of that process, then they have ownership of it. So for example, if it's like, well, I'm going to walk for 30 minutes 3 times a week with my best friend, great. If they've decided that's their target, they're more likely to do it. So make sure they're involved in setting those goals. Assist can be, just giving them the encouragement, building their confidence. It might be helping them address the barriers that are in place. And then arrange. Make sure you're arranging follow-up, which is always the challenge. It's one of the biggest challenges in my practice. And arrange may also be referral to a dietitian or somebody with more specialized training or a more comprehensive program. Sometimes I'm kind of skipping the middle A's because I've done my assessment and I'm talking to the patient about what our options are, and if they are open to seeing a dietitian or someone with more advanced training than I have, I am more than happy to get them involved in other programs, because studies have shown they tend to have more success than I can in primary care. But we know there are a lot of barriers to that, depending on where you practice medicine. Do you even have access to those things? Does insurance cover it? Are patients willing to? But I'm always having those conversations and giving it as an option. So what is CMS covering? And before I go any further, can I just see, I'm just curious, a show of hands, how many people are aware of the CMS guidelines at this point? A few, maybe 5? Okay. I think this will be helpful then. Basically, CMS will cover 1 face-to-face visit every week for the first month, and then 1 visit every other week for months 2 through 6. And then if at that 6-month point the patient has lost at least 3 kilograms, so about 6.5 pounds, then CMS will continue to pay for further visits, which then happen once a month for months 7 through 12. If the patient hasn't lost that target of around 6 pounds, then CMS is going to force a little bit of a break on what they're going to pay for. They want the patient to take 6 months away to reevaluate their readiness. So then 6 months later, you can start the whole process over again and you'll be covered. But for those patients that are meeting the requirements, if you follow this plan, that would be 22 visits in a year, which at first when I heard that number, I thought, wow, that's a lot. But studies have actually shown that increased number of visits, more frequent follow-up, leads to more patients, a greater number of patients losing weight and losing a greater percentage of weight. So, and I think that's part of the reason some programs, commercial programs like Weight Watchers has great success, because they're meeting once a week, that type of a thing. So more frequent contact is best if possible. There are definitely limitations. So they are going to cover primary care providers who are practicing in a primary care setting. So that includes physicians that their specialty is general medicine, family medicine, geriatric medicine, pediatrics, OBGYNs, and internal medicine providers, as well as physician assistants, nurse practitioners, and certified clinical nurse specialists. It may or may not be separately payable with another encounter on the same day. The reference down at the bottom of this, and I think we have the link in our reference section, has all of the details about billing for this and that sort of thing. So depending on your practice setting, kind of depends on what's actually covered as far as same day or not. Now, the benefit doesn't preclude us from referring to other practitioners or multi-component counseling, such as, sending to a dietitian or a psychologist. However, those providers are not going to be covered to directly bill themselves. So depending on your setting, if you have dietitians that maybe fall under your umbrella of coverage in your primary care setting, you may be able to bill incident to the primary care provider and have the dietitian see them, but that just depends on your practice setting. That's not an option in the clinic that I work in. And just don't forget, the patients that have diabetes or renal disease, they are covered to see a dietitian. So make sure you're getting those patients to see those providers, not only for those issues, but they can also address obesity if that's the case. And then, of course, they don't address all of the barriers that we have to deal with, such as time constraints, perhaps not having the confidence or feel like we have the training to know exactly how to do this in a timely manner, as well as, patient and provider negative attitudes about obesity, and we really have to take a look at ourselves when it comes to that. So what can we actually expect to be able to accomplish in primary care? Well, actually maybe more than you think. Studies have shown that primary care providers can, for a lot of patients, get results of modest weight loss that is maintained over time. And I think the most important bullet on this is the 5 to 10% of body weight loss in 6 to 12 months is actually an okay target, because studies have shown that even that little amount of weight loss can have significant improvement in other medical conditions, such as blood pressure, cholesterol, blood sugars, as well as general fitness and mobility. So if you think about that, if you have a 200-pound patient, if they lose 10 to 20 pounds and can maintain it, they are going to see some improvement in some other health conditions. Now, I'm not saying that should be your end target, but again, it doesn't have to be this massive amount or nothing. Something is better than nothing. So I think if we can be better about sharing this kind of information with our patients and maybe start with smaller targets, reach those, and then kind of go from there, I find that kind of works, because sometimes a massive number feels overwhelming to everybody. You're just like, oh, just forget it. That's not going to happen. So, and in spite of knowing all of this, we haven't been great as healthcare providers about making the diagnosis and providing treatment. I'm included in that, trust me. I'm working on it. This slide is pretty busy, and you can look through it, in the handout later on if you want. I don't want to talk about all of it. But the most important thing to take away from this is that studies kind of overall have found that up to 50 to 75% of obese patients are not even getting the diagnosis of obesity, and even fewer are actually having some form of treatment recommended or getting a referral. So there's definitely room for improvement there. I also find the bottom bullet point from that study published in 2010 a little bit shocking. The fact that approximately 40% of physicians, now this was targeting physicians, but I do wonder if the number could be applied to all of us, that 40% possess negative attitudes towards obese patients. So we really need to just take a look and see, what are our barriers and what can we do about it. I know, at least for me, training has felt like a huge issue. We're hopefully going to help out with that some today and give you, some targeted strategies. But, there are other CME courses, other online references that you'll find in the reference section that can be very, very helpful. And you can pick and choose the things that are going to work best for you. It is time consuming. Try to fit it in where you can. Like I said, in primary care, I often have multiple opportunities with some of my patients to broach the subject. And if I spend a few minutes each time targeting a specific thing, I have had some success with that. But there is poor reimbursement, like I said, for some of the comprehensive programs and some of the providers that are, probably better trained than I am. But I do, again, ask your patients, and they can always check with their insurance to see what's covered. And hopefully we're maybe going to start to see a trend in a change in that as well. Medical model strongly encourages or strongly relies on pharmacotherapy. I don't know about you, but I've had plenty of patients that come in and, isn't there a new pill yet, or isn't there anything you can give me for weight loss? And while the medications definitely can have a place for some patients, everybody needs to do the lifestyle stuff, otherwise it's not going to be maintained. So that's obviously an issue as well. And then just provider and patient frustration with prior failed attempts. But it's our job as providers to continue to encourage our patients, even though maybe it's been a frustrating road so far. And just remember, moderate weight loss still can have an impact. And then again, just, think about some of those things that, may be personal barriers as well. So I'm going to turn it over to Patty, and she's going to give you lots of great information.
Okay. I hope I'm the right distance. Is this good? Okay. Just raise your hand if you're not. I'm a little louder speaker than Carrie, so if I'm too loud, give me the tone down since I'm not used to speaking with a microphone. I want to talk about some of the practical strategies that you can really put together and hopefully apply right away in the office setting right now if you're starting to do this. And this is whether it's 2 minutes at the end of any appointment or if you're actually doing these separate appointments now that can be reimbursed for your CMS patients. And keep in mind what we're talking about here is what you can do for your CMS patients. Some insurers are covering more broader dietitians, more prevention, even gym memberships and so forth, but our CMS patients, this is really a first step. I think we will see more. Okay. I want to talk about what I call assumptions before we get going with obesity management. There are journals and journals in my field that have been dedicated to obesity for the last 30 years and beyond that. So there's lots of information out there. But let's talk about a few assumptions. The first is genetics. Genetics accounts for 30 to 40% of the variability of obesity, and we need to say that right off the bat. And our patients need to hear that from us. It's not a weakness, and really have a right attitude as we approach them. More studies are showing that genetics not only impacts metabolism, which you probably are familiar, but also appetite, triggers for appetite, hormonally controlled, and also activity levels. So start thinking about this as you see patterns. People have a greater desire to be more active as well, and they feel that's linked to genes as well. Environment, of course, is our big changing factor right now. So the environment, we've taken a population that is genetically predisposed to obesity, and we put them in an environment, I call it the land of plenty here in the United States. But we're starting to see more and more problems in developing countries for much of the same reason. So what we have is an environment of low activity and poor dietary habits and abundance. So the next time you're in Walmart, if you go to the super Walmart that has the food store, think about what's in all those aisles as you go through that we don't eat, we don't need to eat, and we never need to eat, but we're all eating. So just pay attention to that when you're there. The other thing we kind of say in the obesity world is you have to be a restrained eater today not to gain weight in the present environment. So when I teach this to my students, I say, can I have a show of hands? And feel free to raise your hand. Do you feel you eat till your heart's content? I don't see a hand up in the room. And if there was, somebody would probably maul you because most of us are practicing some level of restrained eating. So you want to increase that awareness. Let me go back and just mention appetite here. Appetite is certainly something we need to overcome. Multiple determinants here and also multiple social psychological factors impacting appetite. Just the last few points here on weight is, as you know, the recidivism is very high with weight loss. There are multiple biological processes working against weight loss and working to allow people to regain their weight. And, from a genetic evolution standpoint, sometimes they use the term survival of the fattest over the course of years rather than the fittest, because starvation was killing people 100 years ago and certainly 1,000 years ago. So we are programmed. And then the psychological issues, I'll revisit this, but many of your patients will come in with underlying psychological issues. Abuse and neglect is very common in depression in obese patients, and we need to be aware that there may be other things going on that, really need to be addressed before we start tackling the obesity issue. Okay. So if we go through just our primary care interventions that Carrie already introduced to you, I will start with screening for obesity and give you a little more information on that. Screening involves BMI. We make our diagnosis on BMI. That's nothing that's new to any of you. Most of the hospitals are automatically doing this if you plug in your weights and heights to your medical record. What's not made is the diagnosis. I'd like to see that diagnosis pop up in the chart as soon as the BMI over 30 comes up in the chart. But you do want to explore family history of obesity. That certainly suggests a genetic pattern. I don't think it hurts to ask about what their children's weights are and so forth. Carrie made an interesting point in why it's important that the primary care provider is involved in this. What you don't realize is, are you still okay with me for the mic right here? Is that good? Okay. what you don't realize is how many people actually don't perceive themselves as obese or even overweight that are, and that's news to them. And they will say, you know, I'm just a husky, bulky guy, and I wear the same size pants I did 20 years ago, but their belt's, you know, down here. And so it's not the same. So that's important. History, of course, of comorbidities to identify risk, and also psychological issues. And I like to focus on pattern of weight gain. So when we're looking at pattern of weight gain, I like to ask, you know, have somebody repeatedly gained weight with their pregnancies and not come back and lost that weight? You know, they're just gaining 15, 20 pounds, and some people are gaining 50, 60 pounds with each pregnancy, and that puts them in a very different category. I also like to ask, what did you weigh in high school? Because it gives me an idea of how long the weight has been a problem. And most people can tell you that. But I cannot tell you how many obese women in their 40s that I have that are well over, you know, 230 pounds, and they'll say, I was thin in high school. And I said, well, do you remember what you weighed as a senior in high school? And they'll say, oh, about 165. Well, at 5'2", 165 is obese, so they still had the problem in high school. They just weren't as obese. And then also you can ask their lowest and highest weight. That gives you a sense if there's some weight cycling going on in their life. And also very important, and I think Carrie again touched on this, is their perception of weight. Do they see themselves as overweight? Is weight important to them? There's very different psychological reasons and also social reasons. Different ethnic groups look at weight differently. Some populations, thin is very much in. Obesity is more accepted in the African American Hispanic population. So we're just looking at differences there. Okay, the second point is dietary or nutritional assessment, and that, of course, is where dietitians live. But it's also where I think we fail, perhaps in clinical practices of primary care providers, because we don't have time to take a good history, some diet history. And I can't tell you how many charts I've seen that say, oh, typical American diet. We need to be specific, and we need to target, because none of us, you know, all eat the same thing. But there are some typical and unfortunate poor typical American eating practices that many of our patients share. So, excuse me. From a dietary and nutritional assessment standpoint, there's different ways you can do this. In a limited time, this is tough in the office. If you have the 15-minute visit for the obesity management, you may. The 24-hour recall basically asks the patient what they're doing. It helps if you can probe and get some details on condiments and beverage consumption and some of the things regarding portion size. The 24-hour recall or usual intake sometimes runs the risk of the patients telling us what we want to hear instead of what their usual intake actually, you know, is, so you can have to tease that out. Food frequency profiles can be helpful because you'll take a 24-hour recall and your patient will say, you know, I never have dessert. But on the food frequency profile, you might ask how many times, you know, a week do you have ice cream? Well, 7 days a week I have ice cream. It didn't count as dessert because I didn't eat it immediately following dinner. I ate it before I went to bed. So, you know, you kind of can do a few little checks and balances on that as well. The other thing I find that can be helpful for primary care, and I'd recommend this with the new CMS, is have the patient actually keep a 3 to 7 day food record before they come back to see you, because this doesn't waste your office time. You can assess that 3 to 7 day food record. I always like to see a weekend day in there because we all eat differently on weekends and we drink differently on weekends, and it's good to see that in there as well. Then what you want to do is look at that information, and it'll take some training to be able to look at that and say, gee, at a glance I can say this is 3,000 calories or 6,000 calories. You're going to, you know, need to familiarize yourself a little more with food. But what you will be able to see is this person eats no fruits and vegetables in their dairy products. And, you know, they're eating a lot of processed foods. That'll jump right out to anyone. So factors patient feels is contributing to weight loss. We might be able to get when are they eating? How's that going? You know, what time and so forth. Are they eating during the course of the day? What triggers it? Are they eating when their kids come home from school and then also eating another dinner an hour and a half later? But what we want to do with these therapies is target them. I think so often the patient gets the 1,800 calorie or 1,500 calorie diet copy at the physician's office, and you know, and they've come to me and said, I don't know what to do with this in my office. They just don't know. So you want to have targeted therapies that are individualized to your patient. Okay, so some of the problem areas, I don't think this will be new to most of you. Beverage consumption is on this list. Sedentary behaviors. I think we often ask the patient, are they exercising and how much they exercise? But to be honest, it's actually also good to find out how much they're engaging in sedentary behaviors. Do they work in an office? Are they watching TV? How many hours of that would be something that could be addressed? Fat and sugar consumption, no surprises there, but that is, of course, in condiments, and a lot can come in beverages and food preparation techniques where we're getting a lot of fried foods. And again, certain, ethnic food choices, such as Mexican food, often has a lot of lard and a lot of that you wouldn't even see because it may or may not be fried. It might not be obvious to you that it's fried, and a little bit of high-fat food can make a difference. And and there's fixes for this, so that's good. Skipping meals. A lot of patients who are obese will actually skip meals, breakfast, of course, being the most commonly skipped meal. The problem with skipping meals is that the patient can often justify then having a bigger lunch or dinner. But from a metabolic standpoint, skipping meals is counterproductive to weight loss. What happens is the body goes into a short-term fast. The body adjusts to its short-term fast between breakfast and lunch. You have a decrease in the basal metabolic rate. You also have muscle burned as well as fat during that short-term fast. And of course, if you went all night and breakfast, you're up to 16 hours before you have lunch. And then when the body gets that food, it's lost muscle, but it's going to gain it back as fat because you don't gain muscle just from eating. So that's something we really need to target for our patients. And then portion size kind of goes without saying, because that's so in the literature right now. But I also want you to think about this when you're taking a history from a patient, because your patient sees their portion, I cannot tell you, as, oh, I eat a regular portion. Well, what is a regular portion? If we look at the dietary guidelines, it says a half a cup. A regular portion to one patient's not another. I always tell my students this story. I was taking a diet history from a man who was morbidly obese and was going to have cardiac surgery, and the physician wanted to take a little weight off of him before he did the surgery. He was so high risk. So I'm taking the diet history, and I had been around the block a few times, and he said, I have a piece of cheese in the afternoon. What are you thinking? Kraft single, a cheese stick? No, his wife told me, that he had the 10-ounce Half Moon pre-portioned piece of cheese. He had the whole pack. But that was a piece of cheese. So I just want to say that, and not to, but your paradigm is not there. Your paradigm may be very different as you're dealing with patients in portion sizes. So make sure you're getting into their paradigm as you're asking those questions. Then eating out, of course, we'll be doing that tonight. Don't watch what I eat at the table. And then also eating after 8 p.m. because a lot of people are nighttime eaters. They want high carbohydrate foods at night. It's kind of soothing and comforting. It helps put you to sleep, but it also puts the weight on. And then what is missing in the diet? We're looking at fruits, vegetables, fiber. This is what's missing in the American diet for everyone. Low-fat dairy. Meals. This has gotten a lot of attention. So many families are not eating meals. This is contributing to the childhood obesity problem. We're not eating at the table. We're eating in front of the TV, and we're eating whatever's quick and fast and easy. So meals is something that's an issue. And then exercise. So, and then to our last point, which is sort of the main point we want to focus on today, is this intensive behavioral counseling. Just out of curiosity, how many of you have been trained in intensive behavior for any subject, not just obesity? How many of you have had training in intensive behavioral counseling? Okay. It doesn't totally surprise me. Here's a nice reality check. You might see this as good news or bad news. And this was part of what Carrie said. We're not targeting this all or none approach to, okay, we have somebody who weighs 220 pounds and we want to get them down to 120 to get into a size 6 wedding dress. We're looking at what's a realistic health change, but we also want to look at how we got where we are in terms of being obese. So if you look at the basic premise that 3,500 calories equals a pound. So if you have an extra 3,500, you'll gain a pound. If you take that away, theoretically, you should lose a pound. But these are some stats. 70% of our obese patients gain 2.5 pounds per year. That's not much. That's not somebody I sit there and say, oh my gosh, that's a glutton, they're eating all this food. But over the course of 15 years, that makes them obese. Okay? If you have an extra 10 calories a day, 10 calories, what is 10 calories? Overweight in 25 years. Overweight in 25 years. 20 calories. Obese in 25 years. 20 calories. I can give up 20 calories a day. Can you? You say that to your patient, not I need to give up 500 or 1,000 calories a day. They're on board. You know, that'll get them on board. And then 100 calories a day, very realistic, 10 pounds per year. If you can give up 100 calories a day, 10 pounds a year. So you lose 10 pounds a year, but if we can keep people from adding 100 calories a day, that keeps them from gaining 10 pounds a year. You know, so just getting these checks and balances on the system. Okay, so what do we also want to do? Set realistic goals, 1 to 3 realistic goals with the patient. And what you can do at initial visit, giving specific information about food choices. You've got to talk food with your patient, not nutrition. Talk food, not nutrition. Meaning you want to say what foods to eat, not be 30% fat. You know, talk food. That doesn't mean, I have a PhD in nutrition and 30% fat means nothing to me. You need to talk food to me too. And then targeting key problems areas. This is why you take the history. So key problem areas, I'll use myself. What would my goals be? Eat breakfast. I don't eat breakfast every day. You didn't get my diet history, okay? So I don't eat breakfast every day. Specifically, don't tell me to eat breakfast. I commute to work. Tell me, have a breakfast bar. You know, I'm not going to have a breakfast in the kitchen. So have a high-protein breakfast bar as a meal replacement. Take a Slim Fast. Those are specific things you could tell me what to do. You could tell me not to eat at night. I could tell myself that every day, but I need to be told that too. And if you said exercise, yes, I aggressively might exercise 2 or 3 days a week, but the piece that's there is you want to do something every day so it's more habitual. And so a 20 minutes or a half hour a day might be a good piece. You could tell me lots of little advice like that, and you can think of that, you know that already, but be specific with the patient for your patient. Okay, and then there's several articles that have alluded to this intensive behavioral therapy targeting these 6 key areas, and I'm just going to give you a few ticklers on each of these here. In each of these areas. Self-monitoring has gotten probably the most attention, and this kind of can go to awareness in the literature. And this is nothing new. This has been in the nutrition literature forever. But it's something you can tell your patients to do. Keep a food diary. Makes them aware of what they're eating, and you can come back and look at that diary and assess it. Logging exercise time, maybe logging sedentary time if that's an issue. Monitoring weight 1 to 2 times per week. I cannot tell you how many patients do not have a scale in their home. You have no idea. No idea. I'd say at least half. At least half of patients I talk to do not have a scale in their home. Also increasing awareness, and you know, I sit there and say you could close your eyes while I read these questions, and I'm going to read them off the monitor here. Am I hungry? Should I eat this? How much should I eat? Think about that. You know, that piece helps everybody. And then also look at listening to hunger and satiety cues. A lot of our working women or women with children are just running. They're eating fast. You know, they're just shoveling it in. I remember sitting at a meal with a lady who had 6 children. I think after 5 minutes, she had the whole thing down, and I thought, yeah, she never had a chance to sit and eat a meal for 15 minutes. That's a barrier, but we can work on that. She wasn't overweight because she never sat down, period. But nonetheless. Okay, then portion size. There's lots of good information online about portion size, so you refer to some of those websites, and I'll refer to those, the ones you're familiar with perhaps already, U.S. Dietary Guidelines, the food pyramid, My Plate websites from the U.S. government have lots of little handouts you can give. One I absolutely love is VA Move, and that's referenced to on the handout. I like their clean, short, concise, crisp handouts. Very good for a CMS patient, not an overwhelming book of information. DASH has stuff. They have a wonderful 25-page booklet, maybe a little too much for most of your patients at one time. So you got to provide examples of normal portion size. People don't know what a normal portion size is. It's the regular. A lot of the food things will make reference to, like you could say your hand, is a 3-ounce chicken breast, okay? But somebody else's hand might be bigger, so I go up to the men and say, well, that's probably a 4-ounce chicken breast. Magic Johnson, that's probably a 10-ounce T-bone. So you have to look at that. But you might compare it to a hockey puck, a baseball, a golf ball. They might use it. Careful with your CMS patients, though. They might not have the paradigm of a hockey puck. We're from Minnesota. But it's a rich kid sport. Hockey is a rich kid sport. Golf is a rich person's sport. So make sure you're making, culturally sensitive comparisons. Measuring food serving, that is cheap. Everybody can get some, measuring cups at the dollar store and have people measure their food portions to really see what they're eating, particularly if they're eating processed foods. And then don't eat out of the bag. This is a piece of advice to give me as well. Don't eat out of the ice cream container. You dig the nut and then you level it off, and then you dig the nut and then you level it off. So you guys know. See, but let your patient hear that from you. Let the patient hear that we're all in this together. We're all fighting this. Every single person in this room, whether you're thin or slightly overweight or even obese, we're all fighting this ourselves. I mean, how much obesity are we preventing? If you're not eating till your heart's content and you're sitting in this room, we're preventing it. Okay, think about that. Give yourself some credit. Okay. Then also we have eating out. There's much stuff in the references on this. I think what I usually tell is that people need to share if they're eating out a large meal. The other thing is if people are eating out all the time, what we know is eating out has contributed to our obesity epidemic. So we know there is a lot more obesity because of eating out. If people eat out every day for lunch, they might be getting 700 to 1,000 calories. If you are my age and my size, you get 1,600 a day. Okay, that's not dieting, that's just to maintain. If you're not doing it, so you cannot have 700 to 1,000 calories every day for lunch and not gain weight. So a healthy lunch option, packing a lunch is a nice bargaining chip for your patient. So just keep those in mind. Lots of, again, stuff online here. Beverage consumption, it's not in the research paper that I showed you, but we know it's a big problem. I certainly have it on my list. I have had patients who have been regular addicts of Coca-Cola, and I'm not picking on Coke, Pepsi, whatever sweetened beverages. And if I can get them off that pump, it might save them 200 to 2,000 calories a day. That's all they need to do. They don't need to deprive themselves of anything else. So what they'll say is, well, I don't like diet soda. No one ever had to drink diet soda. No one died because they did not drink diet soda. They can drink water. What you gotta watch is the other fruits and healthy, that you see. They have you look at the one at Starbucks, the square bottle as a Bolthouse or whatever, 400 calories in there. You should be drinking that out of a shot glass, not that bottle, based on how many calories are in there. Very nutritious. I'd recommend it to my cancer patients in a nanosecond to gain weight, but not my obese patients to lose weight. The problem with soda pop, and this is true with carbohydrates in general, is that they have a high glycemic index. Some of you have heard that term. So you drink your soda, you have your sugar high, okay? Then you go bonk, you have your sugar low, and what do you want to do? Eat. Okay, and that's the same thing for food. So we want to think euglycemia, not to mention it's quick, easy, fast calories, and you can get a lot with the pop here. And of course it has no nutritional value. I did pop that off. I do want to mention alcohol. You want to take a good alcohol history. Lots of calories, and this will contribute to alcohol. And as people eat, they also may, it decreases their awareness and inhibitions, as you know, and then may eat more. So we have to look at alcohol. A lot of calories in alcohol. As a dietitian, I can get the alcohol history that you guys cannot get as the primary care provider. You just slip it into that diet history. It's amazing what you'll be told. Did I go backwards here? I think I did. Okay. Exercise, we kind of talked about that. What I would tell you is that exercise only modestly supports weight loss. Contrary to popular belief, very good for maintenance, very good for prevention. But what I think is important to tell your patients, and my sister who's overweight, hedging into obesity, says, if I wasn't heavy or obese, she wouldn't use that term, I wouldn't exercise. That's her motivation to exercise, to try to lose weight. So even if your patient doesn't lose weight, the health benefits of exercise for fitness, even if they're still overweight, are huge. So I always tell my patients to exercise if they can. Where do we start those people who aren't exercising, though? Their BMIs at 35 and 40. That's tough. So we might try to say 30 minutes of moderate intensity activity. If they can walk, we want them to walk. You want to be specific and targeted again with your exercise recommendations. You probably know as much as I do about recommending these, but I want to say specific and targeted. And also, a lot of patients who can't move around are actually very into doing the resistance training. You know, again, Walmart, skip the food aisle, but go get the 5, 10-pound weights, whatever they might be able to do, and they might be able to do that sitting down, or maybe do the scrunches against the wall where you do sort of squats against the wall. I'd fall off the stage if I demonstrated that, so I won't. But just something that gets their muscles, you know, moving and working into that. Okay, and then lastly, I'll mention sleep hygiene. You know more about sleep hygiene than I do, I'm sure. But there are studies that have shown that the decrease in sleep in the American population has been associated with an increase in obesity. So they started to look at, what is this? Is this just one more poor habit we have, or is there some science to it? And they've actually shown that the disturbance in the sleep cycle actually do impact hormones and metabolism, and you know, your body recovers at sleep. And then, of course, the obvious thing is you can't eat while you're sleeping, so that helps as well. So to just finish up here with a few diet strategies that work, the basic approach is, and this did get cut off, I was hoping it didn't, this is the plate model here from my plate. But you're familiar with these. The one I want to push is the plate model, and everybody should have the poster in their office of the plate that shows half the plate fruits and vegetables, the half of the plate meat and grains, okay? That is what a normal meal should look like, and people need to see that. So I think it's good to have that on there. It's also very simple. The other thing that we know works is the increase in fruits and vegetables. A lot of times I have patients, instead of giving them a list of don'ts, can you commit to eating 5 servings of fruits and vegetables a day? If they can, it's replacing some other junk. They're not eating it over and above, it's replacing some other stuff. Same for low-fat dairy. And shopping the perimeter, you got that message, right? Pay attention when you go to the grocery store to that. It's every grocery store you'll go in. Nutrient mix is also important. We want a higher protein mix for our patients. Promotes satiety and euglycemia. We're not talking the Atkins diet here. We're talking just somewhere between 15 and 30% of the calories coming from protein. And I like to say a protein source at each meal is what I like to say. Carbohydrate control. You want to avoid the peaks and trough in blood sugar. So if we can have the complex carbohydrate, not the simple sugars, kind of gives you that euglycemia. And the biggest issue with fat is simply that it has a ton of calories, and people don't realize how fast they're getting a lot of calories. The other thing that works is the meal replacements. Liquid, and these are the things that have been commercially available, so like the Cambridge diet from years gone by, but the MetaFast and OptiFast are 2 medically supervised programs where they have meal replacements, but also there's many things available over the counter for your patient. So this would be a bar, a liquid supplement that can a Slim Fast, your Zone bar that would be a meal replacement for your patient if they're skipping a meal, or this could replace out their lunch. So that could be something in there. They have about 200 calories, and they might replace a meal that has 500 to 600 calories. And, you know, that gets you your pound a week almost just on one meal, if you're looking at that. The other thing is pre-portioned meals, and these are from anything from your, you know, TV dinners, if I want to call that. We like the healthier choices, the Southpeace, Weight Watchers, and so forth. But again, 250 to 300 calories a meal, about half. And it shows the appropriate portion size. And also, it facilitates compliance that way, and it also is convenient. So that's something that we need to look at for the patient, and it eliminates a difficult food choice. So in terms of prevention, we're just looking at small steps making big differences. I'm just going to finish up here and leave you with what I call the 100-calorie rule. If you save 100 calories a day, okay, that's 10 pounds a year, one way or the other. If you can add 100, that'll give you 200 calories and 20 pounds a year. So that's, you know, what we're at then. Okay, thank you.
Thank you all. Please fill out your evaluations. This is a PA Education Association session, so we have separate small yellow evaluations, and questions will be taken outside. Thank you so much for coming.